Good morning, everyone. Good afternoon, good evening, depending on where you are. Welcome to Innovations in Healthcare Learning in Action Network. We're going to just give everyone a few minutes to log on and get situated before we get going. Okay, looks like we have lots of participants here. Thank you again for joining. We've got an exciting agenda planned today. So I'm going to go ahead and get rolling. So first off on our agenda today, we're going to be presenting a curated evidence database compiled by the folks here at Innovations in Healthcare. Catherine Flowers is going to be presenting that. After that, we have a panel on workforce development and remote training during the COVID-19 pandemic. We hope that you will participate in that. We have reserved 10 minutes at the end for your questions and certainly your experience with remote training as well. Please keep your mic muted and video off when not participating, but we do encourage you to participate. We want to hear your experiences, hear your questions. This is a forum for you to certainly learn from each other and as well as our panel. Please raise your hand to speak. You can literally raise your hand on video or use the button at the bottom of the participants channel or chat at any time, and we'll be taking questions from the chat box. Just as a reminder, this is being recorded and will be posted to the calltopicgroups.io. And please, keep the discussion going if we run out of time on our listserv. So with that, I'm going to turn it over to Katie, who is going to run through our evidence database. Katie, you there?
Yeah, hi, thanks, Judd. Wondering if you could actually, I'm going to share my screen from my side, if that's okay.
Yes.
So I think you'll have to unshare.
Sure.
Yeah. Thanks. Okay, so can you see the presentation?
Yes.
Okay, great. So we're really excited to share with you all today an upcoming resource that we'll be releasing soon. It's a curated evidence tool around COVID-19. And the purpose of us doing this is we've noticed that there's really a lot of evidence out there from many different sources. It's changing day by day, and it varies in quality as well. There's a lot of misinformation out there, a lot of poor quality evidence, and we realize that it's a lot for people to sift through and judge what's really worth paying attention to and what's not, and that innovators are busy and they probably don't have time to do a lot of that. So our objectives in creating this tool is to provide our network innovators, especially you all who are involved in the LAN, with some curated, valuable, and up-to-date information around COVID-19. And also to take the breadth of information that is out there and synthesize it down into a few pages that's more manageable, that you can easily find what you're looking for among some of the most important information out there. This is really still quite a work in progress. There is a lot out there. This is not a small task for us either. So at the moment, we really have these 4 topic categories available, or that will be available within the next week. And those are going to be severity and risk factors, transmission modalities and transmission risk, transmission prevention, and risk communication. Some topic categories that we are planning on releasing over the coming weeks and months are going to be prevention policies, diagnostics, treatment, and collateral consequences on societies and health systems. So that can include things like mental health, increases in domestic violence, that sort of thing. But these are certainly not set in stone. We're not limited to these topics. We very much would like to hear from you all about what it is that you would find the most valuable, what it is that you are looking for, and maybe our challenge to really sort through and find the most helpful resources. So please do reach out if you have thoughts about other topic categories that would be useful for you. So what it is the format. It's going to be basically an Excel workbook with multiple tabs, and I'm actually going to switch my screen to an example of it right now. So so are you seeing the right thing here? Yeah, okay. So as you can see, we've got several tabs along the bottom here, one for each of those categories I mentioned. So transmission modalities and risks, severity, risk factors, transmission prevention, and risk communication. And as we add more topic categories, we'll add more tabs as well along the bottom here. I'm going to go to transmission prevention to show you that. Then within the category, it kind of narrows down into from a broad category into more specific topics. So you can see on the leftmost column here, you've got topics. So for transmission prevention, we have general transmission prevention. And within that, we have the subtopics of mask wearing, social distancing, instant hand wiping. There will likely be more added as well as we continue to work on this, but this is what we have at the moment. We have transmission prevention at home, in clinical settings, and again, there's subtopics within that. And then we've just taken really the most important information. What we find is what's going to be the most important and the most useful for innovators and people in general to know, and included that here in the essential information. And then of course, we've also included the source, so where this is coming from, the date that it's published or last updated. And that's going to be really important to just check on that, because obviously this information is changing all the time. And a link to where we found the information and the full citation there in the end. I'm going to go back to my PowerPoint. Okay, so just a couple disclaimers quickly. We really hope that this is useful for you, and we're going to try to include the best information that we can, as well as the most up-to-date information that we can. But that said, this is not meant to be solely relied upon for any sort of major institutional or policy decisions. It's really meant as a supplement and a starting point for that really important in-depth research. So we really encourage, if you find something useful on this database, on this tool, to follow that link, read more about it, do some of your own research outside of this, but we hope that it is helpful, at least as sort of a starting point to understanding these topics. And then also another point is that this evidence is changing all the time, of course, and we do plan to, as much as we can, keep it updated and current, but we can't necessarily guarantee that each day that it would have the most up-to-date information. Things will change, and we won't be able to keep up with it perfectly in real time, but we will do our best. We plan to release this on this coming Monday, July 13th. We will make it available through Groups.io. I'll make this presentation available through Groups.io as well, so you can, if you need a reminder about any of what I've just said, or you can access that. And then we'll also make an announcement through the newsletter. So we'll do those when it's first released, and then when we update it, which we're thinking it will probably be about once a month that we'll release new versions. Then you will be made aware of those updates as well. For more information, so these are some tools or some resources that we recommend if you are doing some of that more in-depth research or if there's a topic that you're looking into that isn't included in the curated evidence tool that we provide. These are sources that we've really been relying on to fill this out. So these are really our recommended resources. Yeah, those would be good places to start to look for your own research purposes. And then finally, if you have any questions about this or topic suggestions, any feedback for how we can improve it, please reach out to me. My email is right there, catherineflowers@duke.edu. I would love to hear from any and all of you with feedback on how we can make this more useful and valuable to you. So I'll stop my screen share, and I think, Judd, correct me if I'm wrong, but I think we might even have a couple minutes if people have quick questions right now. Judd, I think you're muted.
Yeah, we have a few minutes. So yeah, if anybody in the audience has questions, please feel free to speak up or enter it in the chat. Yes, Anandita, you're muted.
Yes. Hello, everybody. I am Annie. I work as a medical lead in an NGO in India. I think this is helpful to have a resource where we can easily look for things and even provide it to the trainers we create. We do master trainings, create master trainers, so we can share this resource with them. They can find these things. I was wondering if we could add some more things here, like maybe best practices. What are the best practices you have come across and maybe you can use a couple of things, maybe working with people with disabilities. You could something to address stigma. Is there a best practice which has been working somewhere very well, and can we have a repository or something where we can keep putting those? And I think there would be some similar questions or topics in my mind. I would share later. These two come to my mind right away, and I wanted to share those. Right, thank you.
Yeah, thanks so much, Annie. I think, so a couple of points to that. I definitely, as I said, I really do welcome any topic suggestions. So feel free to reach out to that, to the email address I shared, and I'll type it in the chat as well if you have any suggestions for topics, and we'll do the best that we can to include. You know, we can't guarantee that we can include everything just because our capacity is limited, of course, but we will do our best. But the other thing I would say is, you know, we do encourage you all to utilize the groups.io platform. So, you know, one thing that you can also do is post in there if you have requests for if maybe other members of the LAN have resources that they've used, and you can share with each other there. So yeah, but thank you. It's a really good feedback. Thanks.
Any other questions for Katie and the team? All right, please feel free to use the chat to ask questions, and as Katie said, anytime on groups.io as well. Go ahead. Apologize, my computer's a little slow. Skip through these. I apologize. There we go. So I'm excited to have an esteemed panel together for our topic today, workforce development and remote training during the COVID-19 pandemic. Before I ask our panel today to introduce themselves, I'd like to remind everyone please feel free to ask questions of our panel and also to volunteer your experience on the front lines of healthcare on workforce development and remote training in your setting as well. Please make this an interactive discussion. So with that, Dr. Blas, please tell us a little bit about yourself and Mamas del Rio.
Sure, thank you for the invitation. So my name is Magaly Blas. I am a medical epidemiologist and a professor and researcher at Cayetano Heredia Peruvian University. And I am the director and founder of Mamas del Rio, which is a program that aims to improve maternal and child health in rural areas in the Peruvian Amazon. And we empowered community health workers with technology. So the heart of our program are the community health workers who have support through also the training of traditional birth attendants, healthcare provider, and community sensitization. We work in 84 communities along the Amazonas, Ucayali, and Marañón River along 350 kilometers. And also we are working now in the border between Peru and Colombia along 400 kilometers in the Putumayo River. Our communities don't have access to water, electricity, or sanitation.
Great, thank you. Abhinav?
Yeah, hi everyone. I'm Abhinav, co-founder at Bodhi Health Education. Bodhi Health Education essentially provides digital in-service and pre-service training platform and solutions. And we are currently providing this to both the providers market here in India and also to the nursing institutions, academic institutions. And we work essentially on the platform is essentially a subscription model, which the providers subscribe it to, and which their workforce can easily use for in-service training. In this COVID period, we have been able to also work with the academic institutions because there was a lot of, because of the lockdown situations, there were a lot of instances where, normal education training got hampered here. So we've seen that there is an increasing, desire to blend both the instructional education and training with technology-based solutions as well. And we similarly also work with private providers in Indonesia. And that's again an interesting geography for us because remote training becomes very important given the spread of the country. Thank you.
Thank you, Abhinav. David?
Yeah, hi, Judd, can you hear me okay?
Yes.
Great. Sorry, everybody, I had to call in because of computer issues. My name's David Scheiman. I'm the Vice President of LifeNet International. And with LifeNet, we work in sub-Saharan Africa. We work with 220 clinics in very remote areas that are underserved. And we don't build structures. We don't fly in expats. We're all about building local capacity. And this is both on the health side, but also very importantly, we build financial capacity and management because you have all these health workers in clinics, but if they don't know how to keep their books or stock their pharmacy, it's all for naught. And the bottom line for us is we believe that everyone should have access to higher quality health care no matter where they live. Thank you.
Thank you, David. And Cynthia?
Hi, I'm Cynthia Mckinney, and I lead corporate and foundation relations with Project ECHO. And Project ECHO was started by Dr. Sanjeev Arora in 2003 to bring quality and cost-effective healthcare to rural and underserved areas all around the world. And we do this through leveraging simple digital technology to train primary care physicians, nurses, community health workers to bring expertise, but also helping bring specialty care to these areas around the world. And today we have over 400 partners in 40 countries with 153 countries, learners in 153 countries. And when COVID came around, we leveraged our global network to really pivot and address COVID as a crisis. And today we have trained over 500,000 healthcare providers throughout the world in COVID-19 preparedness and response. Thank you.
Thank you, Cynthia, and welcome everyone, the whole panel. Thank you so much for joining us and agreeing to participate. So I'd like to ask a few questions of the panel, and audience, please chime in with questions of your own. So one question I had prepared was, in the primary care delivery setting, how has workforce composition changed? Have you needed to extend the skill set of current providers, bring on new providers, or scale back in some areas? How do you see the workforce composition changing as the prevalence of COVID changes in your particular setting? I put that forth to anyone on the panel. You're welcome to chime in, or I may ask one of you.
So I can start.
Yes,
I am
please.
the first on the list. So basically in Peru, before the COVID epidemic started, there was already an unequal distribution of healthcare professionals, especially in areas outside Lima, which is the capital of Peru. So just to give you an example, in Loreto, which is a region located in the Peruvian Amazon where Mamás del Río operates, there are only 19 health professionals per 10,000 inhabitants. So when the epidemic started and the health personnel started to die, there was an incredible understaffing at the healthcare centers. So imagine if this was happening in urban areas, what was the situation in rural areas where the density of healthcare professionals is even lower. So now what happened in Mamás del Río, which is the program where I work, we train, in Mamás del Río, we work with community health workers who are trained on how to diagnose a pregnancy so that women can start early their prenatal controls, and they also do home visits to pregnant women and newborns with the help of a tablet-based application that helps them not only to gather data so that also they can display health information in the form of videos and pictures. So, and also community health workers can provide safe delivery kits, because 65% of our women deliver at home without the care of any trained healthcare provider. So, as I mentioned, in these rural areas, we don't have access to water, electricity, or sanitation, and they are located, just to provide you a context, along 350 kilometers along the river. And in these 84 communities where we operate, there is only one physician, and the majority of health personnel are actually nurse technicians. So what we found powerful in our program is that it was key that it was based on community health workers, because it helped us to build capacity in each of the communities. So when the quarantine started and the entries to the river were closed, we found that the community health workers were really, really key to manage the epidemic in some way, because of two things. Because there was a direct connection through the community health workers with the communities, so that, for example, we were able to learn, and also the Ministry of Health was able to learn how the communities were responded to the epidemic. For example, how soon the communities closed their entries to the communities, how they were dealing with the entry of foreigners. We also were able to realize that only 15% of healthcare posts were providing care related to maternal and child health, and really the situation was dramatical. In fact, the health visits that community health workers were doing through our program were the only point of contact in related to care that women at these communities were receiving because there were no health centers available. So that was one thing, no? That the community health workers were key to learn how the communities were dealing with the epidemic. And the second thing is that the community health workers also proved to be an important source to send prevention messages related to COVID and also correct several misconceptions that the community has related to this virus. So that we are grateful that we train community health workers. I think they are, especially in rural areas, are a source and an important way to build capacity in the communities so that when the communities are alone, like in the context of this pandemic, they basically are alone because of the closure of the entries and because there is no healthcare provision and because of the government is only focused on the capital and the cities that are more crowded. I think they are a way for the communities to survive in this epidemic.
Judd, this is David. Can I jump in and add to that?
Please.
Yeah, so that was very interesting. We have, in the African sub-Sahara context, one of the big things we first learned is, you know, we never have enough healthcare workers anyway, just like the panel member before said. So the first thing we had to do, you've got to protect your existing workers because things are going on. If they don't feel safe, like in the US, they're not going to go to work. So we very quickly got out PPE and some emergency training to all of them. So I bought up everything I could very quickly, the masks, the gloves, the gowns, and we got that out so they would have initial stock of PPE and just some initial protocol on isolation and what they're supposed to do. So you have to figure out how to do more with less. And not only this, but many places like Uganda, they weren't allowed to use vehicles, and if they couldn't walk to work, you had to figure out how to get them there, maybe bikes or stuff like that. So thirdly, we had to start cross-training all our staff. You have to have people that can do just about anything to fill in the gaps. When you only have a few people, you have to do more with less. And then lastly, we had to just focus, what are the most important things we can focus on right now? Again, there's similarities to the US, and what can we put off later? Now, the challenge is in rural health areas, people only show up for help when they're really sick. So there's not as much elective there that you can put off. But I guess the biggest thing I'll stress is protect and take care of your existing healthcare partners. Thank you.
And I would also add that it's really about task shifting. And so we've already talked about it's building capacity is super important. We don't have enough specialists, specialty care, particularly we don't have enough specialty care in cities, but particularly in rural and underserved areas. And so giving these healthcare workers, nurses, nurse practitioners, primary care physicians, the skill set that they need to be able to treat things. Just because, for example, you're not a gastroenterologist doesn't mean that you can't be treating hepatitis C, for example, if you have the right skills. And so from our perspective, we use case-based learning. It's not enough just to get the information where it needs to be. It's really complexity that has to be mastered over time. And so that's really what we're trying to do with Project ECHO is get the right knowledge in the right place at the right time so that people feel supported and have the skill set to manage complex situations. And that knowledge is changing all the time with COVID, you know, especially in the early days, but even now, I mean, looking at the resources that we were looking at earlier, another month from now, that's going to be quite different than what we had just the prior month. And it's also different in the cultural context. So each of these, how you treat COVID in, say, Kenya is quite different than how you would treat it, say, in Florida, partly because of resources available.
So I'll just add to what all of the panel members have said. So we track a lot of activity which goes on our platform and use analytics heavily. So what we've seen is that the so we very quickly had COVID training, and we focus a lot on how can we impart, like how can we create proxies for practical training, especially for nurses. So we focus a lot on that, which is through demonstrative video based interactive content, which we found to be quite useful. We saw a very interesting trend as to the healthcare providers having more more of their staff going through regular trainings, so that they could create a lot of backup. And what was also happening was that and rightly so, there is a lot of focus on taking care of COVID, I mean, folks who got infected by COVID, but there's an equal important gap which is now which was happening because of the lot of workforce being shifted into COVID responsibilities. So that gap is where the platform really was helping, especially with our clients in Indonesia, where we use a lot of mobile technology based applications to provide solutions. So we saw a very increasing use case happening there during this last 3 months. Plus, what we've also facilitated some of our partners, or some of our clients rather, is to really, I mean, this is a time where we are as a venture are also stretched in creating new stuff. So what we've done is we've also enabled high quality curated content to come over the platform, which could be useful for some of the which could be useful in-house, which the mobile platform is helping them, and also could be, if the healthcare providers really finding value, we could open it for other providers, which include public health providers. So that's what we've seen in the last few months as an interesting trend over the platform. Thank you.
Thank you, Abhinav. We have some questions from the audience, and I think this is a great lead in, and that the questions are around content, the quality content, and around technology of and accessibility of the technology from the community health workers. Can you comment on where to source and or how to produce the quality content, and also sort of any technology challenges as far as transmitting that content?
Sure. I think I can take that and maybe share our learnings. So yes, so exactly, that's a very, very important point. I mean, look, we are in a, it's been a crisis situation. We ourselves, we develop a lot of content on a regular basis. Like, we have a repository on the nursing side. We have a decent enough repository which which caters to a lot of in-service training requirements. But when we were stuck with the pandemic, it was challenging to get new content. But very frankly, there are some excellent resources, CDC, WHO, like Up to Date, and some of the other providers. I can even share a list of those. So we created so what we did was we looked into a lot of, and a lot of organizations have open sourced their content. I think that's been a really, really great collaboration, and we ourselves also looked into and created sort of a very exhaustive list of available resources. So that's something which we would really encourage anybody who is looking for content during this period to focus on. and what could be done, and what we have done in our thing is we've integrated some of this content which is open source, which is available out there to be consumed through mobile applications, which in our case we have created in a way which can work in low bandwidth connectivity using a lot of work. We've worked a lot on the video streaming side of things, and how do we kind of take assessments and so on. So I think what we could do is that we had the platform, and that platform had been developed over a couple of years. So we could easily plug the content which is available from these sources into into the mobile application which we have. And maybe that's been something which is good, but creating content during this time is a huge challenge. I think I would say that it's difficult, but it's quite possible to reprocess some of this content from very credible sources, which could be very useful for providers.
So Project Echo partners with a lot of these content providers. We partner with the WHO, WHO, the CDC, all around the world. We have a particular focus on Africa and actually the Global South as the Global South enters winter. And we're seeing the rise of COVID in so many of the countries. And we actually leveraged a simple digital technology, Zoom technology. We provide Zoom licenses for all of our partners for up to 1,000. And in fact, in certain circumstances, we've had as many as 8,000 or 9,000 people on a call, especially in the early days of COVID when we were trying to get much needed information out as quickly as we possibly could. And so another thing we have when you partner with Echo, we have a resource library, a global resource library where we're actually generating content. It's case-based learning. And so, when you are treating patients, so for example, you're treating a patient with an underlying condition, say a diabetic who also has COVID-19, those are complex situations. It's not like you can write one paper or, read one thing and understand the complexity of that situation. And so we have resources and we actually record everything, and all of that is available on a digital platform that we have.
Just to add to what the panel members have said, at LifeNet, we had to divide up our 220 clinics. Some had access to some connectivity and also even computers or tablets, and some had almost nothing. So we had to have a two-pronged approach. So for the ones with real low connectivity or no connectivity or access to screens, you really have to have some kind of mobile platform that can be used on a regular phone, because they are everywhere, as you know, they're ubiquitous, so not a smartphone. So we did build a platform, a bot using WhatsApp, which is very easy to use, low connectivity where we are in sub-Saharan Africa. And that's to push out messages and diagnosis and symptoms and what they do to community health workers, anybody that wants to access it. But as far as more detailed training, when you get into, you can sometimes have issues with Zoom and other things. So we went to a Moodle platform, which is free, the initial Moodle. It's a great teaching platform. And we have our regular teaching lessons there on infectious disease and things. And also, if there's issues downloading, we can just send those out cheaply, lessons on a motor taxi with a little flash drive. So that's kind of how we got around the low connectivity issues. Thank you.
Well, in our case, we face the same issues as David. In our communities, people don't have access to cell phones. But we took advantage that we have a community health worker in each of the communities who have a tablet with an application. But the challenge now is not only the content, which is very limited in Spanish, although it's available through some organizations, but also how we train these community health workers, because our community health workers have mainly primarily education, so first or second grade. So the trainings that we did before were in-person trainings, very engaging, no PowerPoint presentations, but now we have to train them remotely. So we are creating these videos that are very engaging and that can be also delivered through flash drives that they can connect in the televisions so that they can watch the videos, and this is supported by phone calls or radio communications, which are available in several communities.
Thank you. Sounds like a great mix of creative solutions that are very context specific, from WhatsApp to flash drives to videos and to Zoom. So it's amazing that the type of work that's been going on to be responsive to this, and how technology has been able to enable that. So I guess as far as best practices and what you found to be the most effective, have you had any false starts, and I guess any advice for the audience on what's worked for you? And again, I would encourage other people outside the panel to contribute as well. So
I think
any lessons learned in content development?
I think for ECHO, one of the things we've learned, and this is pre-COVID, but it certainly extends into COVID, is that you really need to understand and we actually touched on this already, but the local context. And so it's, for us, when we go in and partner, we partner with partners on the ground who have, with experts that are in that country. We bring in experts from outside if they are needed, but if they exist, there's trust in the community. And the other thing that I think is really important is it's, when you're talking about learning, particularly if you look at the research in and around adult learners, it's not about just, experts imparting knowledge to, healthcare workers. The healthcare workers themselves have an incredible amount of knowledge. And so what we have found really important is that two-way, what we call all teach, all learn. In ECHO sessions, it's not just the experts. In fact, we limit the amount of time the experts are speaking because it's a community of practice and everyone is learning from each other. And so we have found that is really, in many ways, what differentiates the ECHO model.
Just to add to those good comments, what we've learned in best practices is, if you don't have some kind of digital teaching learning capacity, you're in trouble. By the time a pandemic such as COVID-19 or Ebola comes, it's too late. So it's all about preparing to work on your platform now. I would strongly urge, all of us to think about, do our clinics, our partners, have emergency supply at least 1 month of PPE so our health workers feel safe and can come to work? It'll disappear, or can they make those masks locally? We've been doing that with the gowns. So we got out a 1 month supply just so we could get started. We've developed our digital training. And then thirdly, it was, as was just brought up, well, I guess one big thing I want to say is we as a community here, we should never waste a crisis. So yeah, there's hardship, but this is a great opportunity for all of us to do things better. So we also learned that we want to better collaborate with other NGOs, the Ministry of Health, and other partners, because we all, even on this discussion, I'm hearing some new ideas. We all learn from each other. Everybody knows something the other person doesn't. And if we work together, we can solve big problems. And also, you have to work together sometimes to go before the Ministry of Health. When you really need to bring up an issue, there's more strength in numbers. And we found that when we were ordering PPE from China and places, we can't order the massive quantities required. So you have to band together. So those are just some things we've been learning. Thank you.
David.
I think I'll just add. So yeah, this, I mean, so we kind of took this. So for us, we saw an need rather in the pre-service, areas where we could, provide technology. But that, I mean, it's a great thought. It's a great need. But you need to be really, really careful because because there are constraints and you need to be very, very focused on the ops side to ensure that you can iterate very, very quickly when you are providing a digital platform, because there would be devices, screens, internet bandwidth, connectivity issues which will be working with any which ways. But a lot of issues also are there from a user behavior perspective. You are used to, like in the pre-COVID period, you are used to certain user behaviors which have been kind of factored into the application development, but there are new user behaviors which are happening very, very quickly. So that's something which has which is an area which we have in the initial few weeks we had a lot of issues there, but we've learned that part as well. And as David said, it's important that you look at providers, players who could be local, right? And there could be a lot of interesting collaborative opportunities, which you could kind of work together with. So that's the other learning which I think is worth mentioning here to the group. Thank you.
I think for us, the fact that we introduced technology early into project help us to still, when the entry to the rivers were closed and health facilities were not operating anymore, it was a way to contact the community health workers and also help with the continued provision of healthcare through the home visits. So I think it was key to have very early in the project a focus on introducing, for example, a tablet-based application that now we are adapting to COVID thanks to funding from our government. And the second thing is that we have realized that we are able, even though if we don't have internet or if we don't have phone, there are radio communications, so that we are learning all these possible ways where we can contact the communities to provide them support.
Thank you. So I'd like to sort of follow up on a thread that a few of you brought up in this last one, and that is sort of getting feedback from the providers and from patients, and sort of the all learn concept. And I guess how have you found to keep those channels open and I guess what lessons have you learned or advice that you have for our audience on keeping those feedback loops and the two-directional learning open?
Well, I think I was the one that mentioned what ECHO calls all teach, all learn. And that's an integral part to what we do. It's actually a tagline we often use because it's so important that the learnings, the experts themselves are often learning from the community health workers. So for example, you might have a case-based, a case that's presented by a community health worker from a village that doesn't have refrigeration. And the expert says, well, we think this medication would work. And the community health worker says, yes, but that has to be refrigerated and we don't have any way to do that. And so I think that's the cultural context that comes into play as well. And then it's not just even two-way. As I mentioned, it's the community of practice. And so this is a network. We also will supplement Zoom often with a WhatsApp group because it enables, what we're really doing is telementoring. And so it's really it's guided practice. It's guiding people to become experts. And that doesn't happen in reading a paper or one Zoom call. it happens over time. And so to the other feedback loop that is really important is to look at, to measure your impact. And so with every single session, we send out a survey. At the end, we're collecting data all the time, and it's a continuous improvement process. And so learning from, and because how you improve in a, for us with so many different echoes or programs throughout the world, how you do that improvement is different. How you do it, say, in India for nurse practitioners or say ASHA workers in India versus nurse practitioners in the United States. That's quite different. And so those learnings have to be collected continuously.
Just to add to that, those are really good comments. So we have the WhatsApp groups because they're low bandwidth and anybody can participate in these countries. But our principle is the people that are closest to the situation, they understand it the best and they have the best ideas. So for example, in Malawi, we couldn't get any PPE masks there and our staff didn't feel comfortable coming to work. So we started working on, with local women groups, making the masks. That was good, but they still weren't to the high enough specification. They could get access, believe it or not, to some filter materials with HEPA filter that's very effective. So they're the ones that came up with the idea of making the pouches on the masks and using the filters. That came from them and not us. So none of us have all the answers. We need to constantly be learning from each other. Thank you.
Thank you, David. Anybody else have any thoughts on trying to learn from those closest to them? We can let's see. So go ahead, Abhinav.
Yeah. So I think for us, what's really been very useful, and this is so I think what we did is that for all our interventions, we created WhatsApp groups, which enabled us to interact with the users, or at least even the SPOCs, the point of contacts for each user group on a very real-time basis. I mean, opening it to the entire users was quite distracting and challenging, but just kind of making sure that we had one SPOC in each region who was on that WhatsApp group and we could communicate very, very quickly is something which we did in whatever interventions. And we also had, like, our technology folks also be part of that, because it is very important that what the user is experiencing gets immediately down to the tech guys, so that they then can address some of those issues or even those teething problems in a real-time, quick manner. Thank you.
Great, thank you.
So we don't have, so the communities where we work, the people don't have access to cell phones, so they don't have WhatsApp. So we rely on the training of a person, which is a community health worker, who can now then deploy the information to all the communities. And in this way, as I mentioned, we found several ways to reach even remote areas, especially the ones that are in the border between Peru and Colombia, that are the less accessible, because I mean, you need to fly to not only from Lima to Iquitos, but also to the border in another airplane. And then we have 400 kilometers in the river. So in that way, where we don't have either internet or cell phone in some communities, radio, and I am addressing actually one question of the audience, radio is being an important way, not only to provide information in programs, but also to connect with the people, so that, for example, we do a call through the radio and then they call the participant and then he's able to reach, and then we are able to support them in some way. So that's how we are working in those inaccessible communities. And in those that don't have even radio, well, we have paper. We have to do the trainings through that.
I've got a question from Isaac. Considering non-health workers have access to radio program, how do you use radio communication for training, or was the training specific or just a general message for the public?
Actually, I just addressed that question.
Okay.
You can use it in both ways. I mean, through communication. I mean, so with the messages through all the communities. We also deliver these USBs, which are of flash drives that are important in the communities because they have these TVs where you plug the USB so they can watch the movies because there is no cable or so. But and then through the flash drives we provide training, but also through the flash drives we send audios that can now then be heard in the community. And also the whole community can receive the messages, prevention messages about, for example, how to deal with COVID, what to do if you have symptoms around COVID. And also the radios can also help you to deliver information through the programs that are, but also for communication purposes with the community health workers.
Thank you. And the audience, if anybody in the audience has a specific training story they'd like to share, feel free to request. You may have to request from the host to unmute.
Hey, Judd, can I mention
Yep.
one thing that I think we're missing here? So we've had some fabulous ideas from this panel, very interesting. The one thing I haven't heard come up yet is you not only have to look at the training, the PPE, how we're getting the message out, everything from Zoom to flash drives, to radio, to paper, but we also have to prepare our partners and teams for tough financial times. So many of our organizations have taken a hit here in the US and NGOs around the world during COVID-19, donors pulling back. Many governments in these countries are having issues and they close down the economies. So that's affected the governments, the payments to clinics. And then in our clinics, people pay a small fee. They're not coming to the clinics now because they're afraid or they don't have money. So we really have to, it's not just a health thing. We also have to help them with the finances in managing through these things. So restricting budgets, we had all our clinics partners reduce their budgets by 10%, eliminating or deferring anything non-essential. So let's look at the whole picture here because all these things can affect the healthcare and how we respond to COVID in rural areas. Thank you.
Thanks, David.
Yeah, and to add to that, we have found we actually pivoted pretty much 100% for a short period of time to COVID-19 preparedness and care. And what we found is that, and we're seeing it, we're reading about it, that people, just the regular healthcare situations, whether it's hypertension or diabetes or HIV/AIDS, that people weren't coming in. They were afraid to go to the hospital. They were afraid to get treatment. And so we've actually now not pivoted back, but gone back to normal programming plus COVID-19, really trying to straddle both because we recognize, and our partners were saying, we need to actually be providing for our regular patients. And, it's been very much a tragedy, the number of deaths that are not specifically COVID-19, but are related because of COVID-19 from other disease areas.
Very good point. Thank you. So what a great discussion. Unfortunately, we're right up against time. We heard a lot of great things about lessons for folks out there on workforce development and remote training. I'm just looking at my notes, sort of, quality content can be found open source, protecting workers, think creatively about transportation, and technology being context specific, cross training and leveraging community health workers, in this context is important. And it's important always to have, two-way learning and learning from those closest to the problem and being flexible and adaptive. So awesome stuff. We're going to be putting together a summary and sending it out. I think we could really benefit, the community could really benefit from continuing this conversation online. Abhinav, I might ask that you had said you had compiled a list of content sources. Maybe we can share that online and ask others also to contribute to that list. I'm sure people would be interested in finding, sharing those resources. So thank you again, panel, for joining us today. I think it was very, very educational for all of us, and hope again we can continue this conversation and answer some questions from folks offline. So I'm gonna move on. So as far as next things, our next session is July 22nd, 2 weeks from now, maternal and child health. This is going to be an extended session. I don't know if it might be 90 minutes or 2 hours. We're going to have several guests talking about financing and also the latest innovations in maternal and child health and best practices. As always, we're looking for proposals for initiatives for the land to address both in this format as for calls and for collective working together, as David had suggested, and possibly banding together for policy or advocacy or anything like that, research. So thank you, everyone. Hope stay safe and take care.
Thanks, everyone.
Thanks,
Bye-bye.
panel members. Bye-bye.
Thank you.
Thank you very much.
Thank you. Goodbye.